Hi and welcome to the second section for this module. This section will focus on the radiographic positioning techniques for various anatomical regions in general X-ray imaging. In this video, we will cover surface landmarks, skull, chest and abdomen. Understanding this technique is crucial for accurate patient positioning and optimal imaging. Most anatomical structures are not directly visible on the surface, so we rely on surface landmarks like protuberance and tuberosities for accurate positioning. It is important to consider the differences in body type or pathology among individuals, as these may necessitate modifying the normal placement methods. As you can see here, this table shows the external landmarks that can be used in patient positioning. Feel free to pause and read. Now, let's move on to the skull. There are 4 common projections related to the skull, but only lateral and cut well 15 degrees will be covered in this video. The skull radiograph should visualize the lateral cranial cortices, crista galli, and oblique orbital lines that help in detecting rotation by evaluating the distance between them. Meanwhile, the visualization of petrous ridges and supraorbital rims will help in detecting the OML misalignment. In a correct alignment, the petrous ridges are demonstrated horizontally through the lower third of the orbits. However, if the petrous ridges are stated inferior or superior to where they should be, this is due to incorrect chin alignment. Next is the lateral skull. Radiographers should evaluate the superimposition of mandibular rami, external auditory canals, greater wings of sphenoid, orbital roof, and anterior cranial cortices. If one is located anterior to the other, then the skull is rotated, while if it is located superior to the other, then the skull is tilted. Next, chest PA is the most common X-ray examination requested. In detecting rotation of the chest, evaluate the distance between vertebral column and the sternal ends of sternoclavicular joints. Check for the visualization of apical lung field and the degree of lung and heart foreshortening if tilting of mid-coronal plane is suspected. Also, check the location of the manubrium to determine if the patient is tilting forward or backward. Meanwhile, a full lung erection will visualize 10 to 11 posterior ribs above the diaphragm. The last topic for this video is abdomen. The most common projection for abdomen is AP-supine. To detect abdominal rotation, compare the distance from pedicles to the spinous processes on each side and evaluate the centering of sacrum within the inlet pelvis. This is the comparison between AP-erect and AP-supine projection. In AP-supine, the region should include the spinous process of the 11 thoracic vertebra until the obturator foramen. Meanwhile, in AP-erect, the mean thoracic vertebra and the diaphragm should be included. This is the summary of abdomen positioning. You can also learn the difference between scoliosis and rotation. That's all for this video. Next, you will learn about vertebra and pelvic radiograph.